Namaskar. I'm from Agri Medical College, second year of orthopaedic. I'm going to present this short case.
How we are not able to see the knee which is affected in the crack.
You are presenting it as a knee case?
No sir, distal tibia non.
That is the diagnosis. So, first, you see, we always talk that in the short case, you are supposed to answer 4 queries. 4 things have to be answered. First thing is, what is your diagnosis? Second is, why do you say so? Now, in this, what we expect is clinical, not the history or history can only be corroborative at the end, but the findings, the clinical findings. Okay, and before this, what else can it be? Differential diagnosis. And the last question or the last issue is the management. How will you manage? So let's go in that sequence. Your diagnosis is non-union of the distal tibia. Distal tibia or distal tibia and fibula?
Tibia and fibula.
Both, there is a non-union. Okay. So, why do you say that this is a non-union of the distal tibia and fibula? What are the clinical findings?
So the clinical findings to confirm my diagnosis. Firstly,
you just enumerate 5 clinical signs which gives everybody a clue or confirm that this is clinical without touching it. You have examined. Why do you examine again?
There is abnormal mobility.
Very good.
In 2 perpendicular planes.
Abnormal mobility.
Which is painless.
Yes. Yeah, you have to qualify.
It is painless abnormal.
Yes, abnormal mobility.
In all directions. See, you said 2 perpendicular planes. Better to say in all. Wherever you move, it is moving, isn't it? There is a normal mobility. Okay.
Secondly, there is a presence of crepitus. Crepitus is present.
This is sign of non-union.
Even a fresh fracture has a crepitus.
Crepitus is the fracture also.
It is only in a fresh fracture. After non-union, the ends become fibrous, sclerosed, then there is no crepitus, there is interposition of tissues in between. Is there really a crepitus here? But does this support the diagnosis of a non-union if there is a crepitus? Would you like to modify?
Go ahead.
But crepitus is not a sign of non-union. Forget about it. Next.
Painless abnormal mobility, we all agree. Anything else?
There is a shortening of the leg.
Okay. How much?
1.5 cm shortening compared to normal. The distal fragment is rotated externally. The distal end of the
That will be in the medullary also. Why you say it is non-union? Something to do with the rotation.
there is no pain on deep palpation. The fracture side, the exact borders cannot be palpated.
You see, as far as tibia is concerned, tibia is a bone in which the anteromedial border is subcutaneous, isn't it? You have that shin. So, you should probably, before saying that it is not patable, you should think twice. We are not challenging your finding, but we want that it should be, you should give it a second thought.
Things are unpalatable.
Okay. So if you are saying it is a non-union of the tibia, what we want to know is that can you insinuate your fingers into a defect? Is there a defect? Is it a gap non-union? Is it overriding? What is the cause of the shortening? Once you say there is shortening, what is the cause of the shortening? Dwell on that. And by palpating the bone, the shin, I think you can get a good clue whether there is overriding or there is a gap.
A gap or overriding?
There is no gap.
Is there any wound in an association with that?
There are healed wounds.
There are healed wounds there. So this means that this, to start with, this may have been an open. This gives you a clue. There is a wound. Healed wound means this may have been an open. So if it is an open fracture, there is a chance that there may be a gap situation. So just to cover that up, simple palpation can give you that. Is there any evidence of a gap, or is it overriding or what?
There is no gap.
Okay.
There is overriding.
Even the fibula sometimes gives you a. Alright, what else? Have you examined the proximal and the distal joints in this case? Is there any finding there?
The patient, the proximal knee joint is normal in a range of motion,
Okay.
whereas the ankle joint is comparatively stiff.
Comparatively stiff.
Stiff as compared to the normal.
So-
range of motion.
Which movements are compromised?
Sir, dorsiflexion is compromised.
By how many degrees? See, this is a short case. This is a simple short case, and when you get a simple case, it is zero tolerance. Zero tolerance. You can't afford to make any mistake. If it is a difficult case, it's easier to pass. In an easy case, it's more difficult to pass. Remember that. So all these measurements need to be near accurate. And it is very easy. You have to just ask him to do it on the normal side and compare it. What is the deficit? थोड़ा कैमरा से वो टांग का वो पोर्शन फोकस कराओ जहाँ पे स्कार है या कुछ है, थोड़ा साइड से देखिए.
खींचो.
पंचावरती करा.
So there is practically no dorsiflexion movement possible, and the EHL, rather either there is stiffness in the toes or passive movement is possible. Though it is restricted, but passive movement is possible. No, that is not there. So there is a finding when he starts dorsiflexing, the skin gets puckered just on the dorsal aspect of the ankle.
There is a check-in phenomenon. Check-in phenomenon.
Especially with the reverse direction.
FHL. FHL is very closely attached to the fibula, which gets stuck. That's called check-in. And then is stuck. The spination of this.
Is there any front?
What is chakrin?
When you are checking the range of motion of the ankle, there is a movement at the flexor side itself. So unless you stabilize the lower end of the tibia with your hand, you are not able to demonstrate the true movement is actually taking at the ankle joint. But movement is being transmitted to the flexor. It is so close to the joint that ankle movement is seems to be more than what it actually is because of the movement that is taking place. You have to take all these precautions when you are demonstrating.
Did you check the sensations in the sole and the dorsum of the foot?
Yes, sir.
Is it normal?
Sections are decrease around the thumb.
Decrease around the thumb.
Sir, in the first
grade
Thumb
2.
means frontal
Great.
surface, dorsal surface,
dorsal.
dorsal surface. So which dermatome is it? This one is on the sole.
L4.
This is L5 dermatome. Is there a possibility that there is some neurological difference? Just now we demonstrated that he is dorsiflexing, but is getting there's a skin puckering, so there is adherence. So probably the nerve seems to be intact. Okay? What about the plantar flexion? Is there any active plantar flexion there? So, you see, it appears that your examination has only been focused at the local non-moving side. We have not done a very exhaustive examination of the distal joint, which is very important.
And problem.
There are a lot of clues there. Okay?
What about transmitted movement? Transmitted movement? FM. That is not a sign of non-union?
You should also talk about passive movements. See, because if active movements are lagging behind passive movements, this is another sign of tendon adherence. Okay? Because it seems that the passive movement is more than the active movement in this way. Okay? Go ahead. Vessels, what about the vessels? Dorsalis pedis and posterior tibial, are they palpable or not? Not. It's an important finding. The pulsations you do not feel. Both pulsations or one pulsation? Both you do not feel.
How you examine? You examine a normal cell. First show how
How many people know what is check rein deformity? Dr. Gautam has just told. Anyone in the house? Everybody say yes. Nobody knows. What is check rein? Liberty deformity. तुम्हें लगी भी है? नहीं. When you have seen the horse, and when you pull the rein, it goes like this. Same thing happened with the toe, because the tendon FSL is stuck. When you try to do it like this, it goes like this. That is known as check rein deformity.
Dorsiflex the ankle, the toe goes down.
It goes down automatically, because the flexuralis longus is adherent to the posterior. That is check rein deformity. One thing I can, very small, not pertaining to examination, you have to be very clear that I know or I don't know. If you pretend I know, you leave all the possibilities that you know, ever. But if you will say I don't know, there are large number of possibilities that you may likely to know at one time or other time. So you should be very clear in your mind whether you know or whether you don't know. The moment say I know, and if you don't know, then there is no possibility that you will ever know. But if you accept I don't know, there is a large number of possibilities. At one stage or other stage, you are likely to know. Somebody will tell you a time because you accept that you don't know. So if you don't know, you can ask. This is a class. You can ask any type of nonsense questions, thinking that everybody knows except me. But most of the time, many people, they don't know. You should have a courage to say that I don't know. Then only
Then there is a
possibility. Dr. Gautam has explained everything, but you did not get any point what is check rein deformity.
Another finding out the range of motion of the subtalar joint. Now this fourth one leg patient, that is also equally important. What is the correct method of checking the movement of the subtalar joint? Can you demonstrate to me? Because that is also likely to be affected. Tendons are involved. What is the correct method of finding out the subtalar joint motion in isolation?
By the way, the posterior tibial I feel is present, but I could not feel the dorsal surface. So at least one major blood vessel is functioning in this particular patient. Okay?
Why you cannot
Maybe there is. What is the possibility? ये है प्राप्त क्या हुआ है? There was open wound. अरे आप क्या हुआ है? दोनों पैरों में
Swelling. Lot of swelling. Lot of swelling there.
you say total upset? Think through that. Not every single. Don't take like that. Total upset.
And if you say both are active, both are
Because like does he have any fixed flexion deformity of the knee? देखने में थोड़ा ऐसे लग रहा है, I don't know. Can you show me? Morning doctor, I think you demonstrated the correct method. Maybe subtle deformities can be picked up by that method. करके दिखाओ जरा. Let us see that method which was demonstrated to you. You attended this lecture in the morning? अच्छा, you didn't attend. Okay, let's check for. Does he have any fixed flexion deformity of the knee on the affected side? Is this? अच्छा, range of motion करके दिखाना तो दिखाओ. Does he have full range of motion? करो जरा तो. टच करो आखिर तक. Subtalar joint motion.
क्या कर रहे हो वो? क्या कर रहे हो?
Anterior part of the talus is broader than the posterior part. When you dorsiflex the ankle joint is long. And if now you can perform any motion, this is subtalar. It is a very little motion. If you do it like this, it appears much more. But you have to lock the talus inside the ankle mortise to specifically look for the subtalar motion. This is the correct.
So now what will you do for it?
I will investigate him further by doing radiograph.
X-rays. Do we have the X-rays? Put them on.
It depends. No, I don't think so. The proper presentation नहीं है रे, just case discussion हो रहा है. को interrupt कर रहा है ना बहुत. See, और तुमने अगर देखा है ना, हाँ, कुछ तो है उधर. No, it is not. It is theoretically bone only. टिबिया वाले. सुनना, क्या बोल रहा हूँ कि
You speak a little louder.
It was primarily a compound for which excellent setter was applied, and wound was debrided.
All this you are, after seeing the X-ray, you can make. Okay.
Then the excellent setter was removed, and the wounds are also settled, but still the patient has difficulty in walking.
What? एक्सरे फाइंडिंग नहीं बोल रहे हैं.
No, you see, once you have made a clinical diagnosis of a non-union, we expect that you should tell us radiologically if you are finding any signs, radiological signs of non-union. Okay.
On the anterior posterior view of the tibial fibula, we can see the gap between the two fractures in the proximal distance. Sclerosis of the fracture margins.
Okay. How old is this non-union? 5.5. 6 months. Is there any timeline definition also
9 months.
for non-union?
9 months, no? USFD 9 months. Failure progression for 3 months. Especially for tibia.
9 months. Tibia?
Tibia for 6 months or 9 months?
Okay, go on.
USFD वही है ना, 9 months ही है ना.
The margins are closed.
There is a
हाँ, तेरे को पता है.
So gap. Okay, there is a
6 months, ना?
both on AP and lateral or it's only AP? Is there any fragmentation? Butterfly fragment there?
Necrotic fragment है ना बीच में.
there is one
Lateral में दिख रहा है.
of the fibula which is
lateral में इधर दिख रहा है.
So what kind of a non-union is this? Comminuted or? हाँ. तुझे पता है exam is a totally different thing. Totally different. ऐसा नहीं है. सुनते रहते तेरे को करेक्ट नहीं करते कुछ. Very rarely दिल करेक्ट. Just listen. Why? Tell me why. That's all. कुछ हाँ या ना नहीं बोलता है. सही या गलत कुछ नहीं बोलता है. It's totally different. मुझे पता है ना 2 एग्जाम के लिए गया मैं. Totally different ball game.
So what you see is that there is a translation of the distal fragments of both tibia and fibula. There is a combination of both bones, tibia and fibula. You can see some loose fragments lying intramedullary in this area. And in addition to the translation, there is an overriding. That is why you have seen there is a shortening. So you should be able to explain your clinical findings based on what you have seen over here. And you really can't call these bone ends very sclerotic.
They're not.
That is the cortical margin, because of the digital X-ray you see it is very dense. But to call this margin sclerotic, I would not agree. Is it?
No.
No.
And is the medullary canal closed?
No, it's open.
No. So can you tell us what, in your opinion, are the reasons for non-union at this site, this patient? In this patient, what are the reasons for non-union?
firstly the type of injury, it was a compound injury.
So one is, it was an open injury to start, okay?
It was contaminated at the time of trauma.
How do you know it was contaminated?
As per history,
History. The same problem is cropping up again. You see, we have been talking to you, base your evidence on the basis of clinical findings. Let's not talk about history. Because the history gives you a cause for non-union. First, let us exhaust the clinical findings. It was an open fracture. Is there any evidence of infection now? Is it an infected non-union or it is a non-infected non-union?
It is not infected now.
Not infected. There are some wounds there.
There are wounds, but the temperature is.
Are they discharging pus? Can you?
There is no discharging.
Did you squeeze and see?
There is no discharging at the fracture site. There is.
It's protruding out. So then, if there is evidence pointing towards the possibility of an open fracture having been infected, I think you should take that into account. That may also be an additional reason. What else? So open fracture, infection, continuing infection. What else? Number 3.
Sir, the non-union is more common in tibia fracture.
Why is it more common?
Injury generally affect the vascularity.
अभी उसकी बारी है ना इसके बाद TP
Even if it is not compound,
थक गया वो
in close fracture also, is this a site of usually a site of non-union? Then what is the reason?
Because the vascularity is usually.
What do you mean by vascularity? Where does the nutrient artery for tibia make its entrance into the bone? See, these are all important things.
What?
Can anybody else come in?
diapers.
Why is distal tibia a site of non-union? Related to blood supply. So the nutrient artery is entering in the proximal 1/3. Okay? And there are no anastomosis there. Intramedullary travels there, and if there is a cutoff, if there is a fracture, then you have a vascular proximal fragment coming in contact with an avascular distal fragment. So there is a lack of blood supply there. That can also be a cause. What else?
The patient himself is a smoker.
First, tell us the local causes. Local causes. Could there be a possibility of a soft tissue interposition? No. Because you find that the muscle is getting, it is not acting, it is stuck somewhere. There is a possibility. There may be a soft tissue interposition. Look at the nature of injury. So much of fragmentation. It's a high energy trauma, which in addition would have inflicted loss of periosteal blood supply. See, we are talking about intramedullary blood supply being cut off. But if you look at the amount of fragmentation, it's a high energy trauma. So the periosteal blood supply probably is also stripped off. So there's a very high level of avascular condition there. In addition to the possibility of whatever we have discussed, the infection being there, open fracture, initially the hematoma has been drained off. So all these are contributory findings which are leading to the non-union and a systemic finding that he is a smoker. That is adding on to it. What will you do for him?
I will first investigate whether there is infection present at the site.
How will you investigate? What investigation?
I will do blood investigations like program accordingly and check for infection. And
So is that the only indicator? That may be corroborative. But if there is a pus discharge, if there is a bone fragment which is visible, obviously there is local infection.
I will send the discharge for culture and sensitivity and accordingly antibiotics.
So you have central discharge, the lab says no growth. Is it possible or not? No growth in spite of pus being sent for culture. Possible. There is no growth.
He's been given antibiotics
What will you
prior
do?
to this one.
ESR is 25. CRP is 8. What will you do? Prophylactic antibiotic. Will it reach this site? What is the probability of the antibiotic reaching this site?
Vascularity.
Is it highly possible, remote possibility, reasonable possibility? What do you think? We have discussed that it's a situation where there is lack of blood supply. Blood supply is not reaching there. So your antibiotics also have a remote chance of reaching there. So probably that may not be helping even if you give him a pre-operative course of antibiotics.
So indirectly,
Would you operate or not? Would you treat him conservatively or some surgery is required? Let's get on to the let's not beat about the bush. Antibiotic here, it is all.
I would operate.
You will be operating. What operation?
I will like to go for Elizaro ring center or
Elizaro ring fixator.
or LRS.
No, what is? See, let's talk about the basic
I will
basic principles.
I will
See,
पहले इन्फेक्शन तो क्लियर करना पड़ेगा.
see what is expected in this kind of a case is you have analyzed what are the reasons why he has developed non-India and how will you be able to control these reasons. So one of the reasons is infection. Second reason, he has got an instability. Third reason, he has got a very poor blood supply. So these are the three main factors and maybe some loose fragments which are avascular. So how will you be able to tackle that? So your treatment plan has to be aimed at treating all these factors which are responsible for resulting into this kind of a non-injury. Okay. So with these guidelines, now you start analyzing and planning your treatment. Okay, how will you go about it? You are right in saying that you will do a ring fixator. But just doing a ring fixator isn't going to be enough. How will you plan your treatment for putting a ring fixator? I have told you that these are different reasons why he has landed up with problems. So you tackle them. How will you do that? I have given you all the track to think and come on the line. Anybody else? Yes. Yes, he is Dr. Jayan Sharma's resident. I think a lot of work on Elizaro. So I think he will be able to definitely give us a very concrete idea. Yes, go ahead.
Not just by saying Elizaro. I open the fracture site. I remove the. I try the wood.
Put it on.
Sir, I open the fracture site. Sir, I'll debride the wound. Sir, if there is any sequestrum, I'll remove it. If there's a gap, and if the infection is absent, then I'll put the bone graft and I'll apply an external fixator.
Mind well, what are you saying? Bone grafts. See, this is an infected non-union. The patient is having a discharging wound. In that you want to put your bone grafts?
It's a bone cement with antibiotic impregnated bone cement and implant. Stage 1 procedure. With an external fixator in the form of an LRS. Whatever.
And how will you put the bone cement?
So bone cement mixed with antibiotic.
But will you put antibiotic beads or you will put an antibiotic block?
Antibiotic blocks.
What
You
is-
are referring to the masculate technique,
Are you referring to muscular technique?
but then you will have to break a gap.
Yeah, you will have to create a gap, fill up that gap, and
block of cement.
put a antibiotic cement block in that. And then what do you expect to happen?
After 30 days or 45 days, remove the bone block.
What happens?
There will be formation of a
Induced membrane. Induced membrane.
There will be a formation of membrane around the block, which is going to work like,
so it will give an
Osteogenic.
it is going to work like a periosteum for that, the bone that you plan to
Like
put
a
inside.
biological chamber.
Yeah, it's a biological chamber.
But do you think it is a good case? How much will you excise? It's a comminuted fracture. How much will you excite? How much gap will you create? Do you think this is a good case?
You see, I think this is a difficult one. For any person, any experienced surgeon also, this is a difficult one. But at the postgraduate level, I think it's better if we stick to the principles. Now, we have already made some assessments, and the primary considerations that we have arrived at are first and foremost vascularity. Okay, there is severe loss of vascularity in that area, and till the time that you create some conditions for increasing that blood supply, whatever you do is likely to give you suboptimal results. Whatever you do, whatever, there are so many techniques which we can talk about, but the bottom line is the blood supply should improve. If you can significantly improve the blood supply in this region, probably the infection will get taken care of by the fact that now his own body defense mechanisms will start reaching that focus of infection. Whatever antibiotics you give him intravenously or orally will be having access to the site of infection. So, principles of increasing the blood supply probably need to be there. We have a very good, you talked about Elizarov. Elizarov is the pioneer of a procedure which is known as fragment transportation procedure. And where there is a procedure which involves a corticotomy being performed in the metaphyseal area. Probably in this case, the suitable area is the proximal area. One of the benefits of doing a corticotomy, which has been observed by Elizarov and by other workers and proved, it's a proven work, that it is not only the site where the osteotomy is done or corticotomy is done, but increases the overall blood supply of the entire limb. So much so that this procedure has now been adapted by the general surgeons to treat Burgess disease. The increase in blood supply is not once, twice or thrice, but probably much more than that, maybe 100 times. So probably corticotomy, Elizarov procedure if we're talking about, we should talk about corticotomy. We should talk about probably doing a fragment transportation procedure. It is been said by Elizarov that the infection burns, it gets burned in the region, in the fire of the region. Okay, so you can use that. And for your knowledge, Elizarov probably did not have any excess the process of bone grafting. If you look at the pure Elizardo's work, he never believed in bone grafting procedures. But since we are tuned to bone grafting procedures, we have found that in some cases, in spite of the docking having been achieved, sometimes union becomes a problem, or it takes a longer period of time. So, in view of the fragmentation which is there, maybe a good idea to do supplementary cancellous bone grafting. So we are utilizing so many principles. We are utilizing the principle of increasing contact with the bone by doing a fragment transportation. We are increasing the blood supply by doing that corticotomy there. We are also providing conventional cancellous bone grafting, which we are so tuned to doing for bone grafting, for non-union anywhere. Anywhere there is a non-union, the basic principle is improve stabilization, fracture stabilization, and do bone grafting. I think if we combine all these, and if that is narrated by a postgraduate in the exam.
So what to summarize, Shivash, let me just summarize. So to summarize, I think what you should tell is that you have to tackle the different problems that we enumerated. So to take care of the infection, to take care of the bone loss, and after cutting whatever more shorting you are going to land up with, to take care of the soft tissues, I think one of the best options is doing an Elizardo. So you open it up, freshen the bone ends, do acute docking, put bone ends together, whatever freshened bone ends you have achieved, and after putting a fixator, you do a proximal corticotomy, and after a week you start doing transport of that fragment. So as we discussed that the infection burns in the fire of regenerate, you will go on getting regenerate from the proximal side, and that will improve the vascularity. So you have improved the contact. By putting a fixator, you have improved the stability. By doing a corticotomy and doing distraction, you are going to achieve the vascularity. And now the last part that is going to remain is problem, because the fracture is very distal and he has got a lot of stiffness of the ankle. So normally what is recommended in an Elizardo is that you allow them weight bearing. But because this ankle is very stiff, if you allow weight bearing, the distal fragment being very small with a stiff ankle, you will land up with a lot of strain on the docking side. So I would go ahead and recommend that you should put even one additional ring in the foot by which you can stabilize the ankle also, so that there will not be much movement, which will not produce strain on the docking side. If you enumerate these points, I think it should cover up everything. So you have tackled all the factors. He is a smoker, you tell him to stop smoking. You try to convince him for that. And local factors you tackle by putting on a fixator and doing a corticotomy. I think that should take care of the entire problem. Is it okay? Okay.
No, he wanted to say either Elizardo or Nagasa. I want to
Yeah.
What is the
I think LRS will not be an ideal option for this. Yeah, that is why. Yeah. No, and then you can't stabilize the foot, because in this situation with a stiff ankle, you need stabilizing the ankle also. I think with this we have finished these two cases, and then we go to